No, you're right.
Okay. This presentation is on home oxygen and the Hosar service. The aims of oxygen therapy, firstly, is to relieve hypoxia, reduce work of breathing, reduce work of the heart, and in chronic disease, it can help avoid increasing hypercapnia. Who will benefit from oxygen? Acute hypoxia in emergency situations with COVID-19 patients. At present, the BTS guidelines recommend that oxygen be prescribed using a target saturation range rather than by device and flow rate, which often require frequent alteration. Other patients that benefit from oxygen and who may also be on oxygen already include COPD patients, bronchiectasis, CF, interstitial lung disease, lung cancer patients, pulmonary hypertension, and severe heart disease. Types of therapy. Emergency oxygen use is used during an acute admission to hospital or during an episode of treatment in community when overseen by consultants. This would particularly happen with acute care at home team. LTOT, also known as long-term oxygen therapy, is used to stabilise oxygen levels for at least 15 hours per day. Nocturnal oxygen therapy is used to improve oxygen therapy during sleep. Ambulatory oxygen therapy is used to improve oxygen levels during activity. Palliative oxygen therapy is used to manage severe intractable breathlessness. And short burst oxygen therapy, there is very little evidence to support this. Patients at home that you would likely see with this are your COPD patients, your ILD patients, and bronchiectasis patients. Delivery devices that are used for oxygen. In the hospital, oxygen is piped. At home, you would normally see the oxygen concentrators, and there is also oxygen cylinders and liquid oxygen. The delivery of oxygen therapy can be done through various modes. First of all, your nasal cannula is uncontrolled variable performance. It is ordered in litres per minute, 1 to 6 litres a minute, which is approximately 24 to 44% of fraction of inspired oxygen. This will depend on oxygen flow rate, patient's inspiratory flow, the volume, and the pattern of breathing. This device is comfortable and it is easily tolerated by the patient. There is no rebreathing of CO2, carbon dioxide, and the patient can eat, drink, and talk while this is in situ. And it's much preferred by patients compared to a simple mask. It is relatively inexpensive. The disadvantage of this device is it can provide variable concentration, it can dry the nasal passages, mouth breathing, and severe shortness of breath. Also available in the community is an oxy mask, which can be used to deliver oxygen from 1 to 15 litres. This device can entrain oxygen via an open mask. It delivers a broad range of oxygen in a safe manner, and it does not cause rebreathing of exhaled carbon dioxide at low flow oxygen. The mask is flexible and it is less claustrophobic, and it can help to entrain more oxygen. Nebulizers. Infection Prevention and Control Southern Trust advice that nebulizers can be used for patients with confirmed coronavirus as long as the nebulizer is cleaned down according to the manufacturer's guidance and the filter is changed between each patient. Nebulizer will remain with the patient for the duration of the illness. It should also be noted that some patients will have their own nebulizer also, and some nebulizers can also be lent out by the community respiratory team. Oxygen saturation ranges. Normal daytime oxygen sats range in healthy adults with sats up between 96 to 98%. Transit dips may be common during sleep. For the majority of patients, those who have no conditions predisposing to CO2, carbon dioxide retention, oxygen may be administered to achieve a target oxygen saturation of 94 to 98%. In some patients, the administration of excess oxygen can lead to carbon dioxide retention and type 2 respiratory failure. Oxygen may be administered to achieve a target oxygen saturation of 88 to 92%. These patients should be known to the community respiratory team and should have a yellow alert bracelet, alert card and Venturi masks. Patients most at risk of CO2 retention include those with COPD, cystic fibrosis, chronic neuromuscular disorders such as MS, chest wall disorders and morbid obesity. This can occur even with low levels of supplementary oxygen in sensitive patients. CO2 retention. A percentage of patients with COPD have a ventilatory drive which is dependent on hypoxia. Given these patients, high flow oxygen causes them to reduce their ventilation, therefore increasing their carbon dioxide even further. A normal PA CO2 equates to 4.1 kPa to 6.0 kPa. Increase in carbon dioxide indicates CO2 retention and type 2 respiratory failure in patients with COPD. Signs and symptoms of CO2 retention. Headaches is one of the major signs, along with lethargy, drowsiness, confusing, a bounding pulse and raised JVP, a flapping tremor, and severe cases are coma and death. Sometimes the patient may not be aware of this, and it is more the relatives that are with the patients that would be aware of these symptoms. So it is important that this is highlighted to relatives when you are educating the patient and the relatives on oxygen use. COPD alert cards are given out to the patients if they are a CO2 retainer, they have previous episodes in hospital which has required them to have non-invasive ventilation. Their oxygen saturations aim between 88 and 92% normally, some less than this, and there is a yellow alert band. In the picture below is a card that is given out to the patient, an alert card. HOSAR, which stands for the Home Oxygen Service and Review. This is a new service that is delivered by the respiratory teams in the 3 localities, Lurgan, Newry and Armagh. Referrals are not confined to respiratory patients. It is a standardised approach to an assessment of oxygen needs. If client in the community, they can ring for advice to determine if the referral to the service is appropriate. HOSAR. During this assessment, a complete holistic assessment is carried out for long-term oxygen therapy and ambulatory oxygen therapy. This will also involve the team carrying out a risk assessment, a consent form which is signed by the patient, and a copy is given to them, and a copy is also retained by the nurse and the physio during the clinic, and this is added to Paris. The patient is educated and also the carers. We offer a referral to Northern Ireland Fire Service for a home safety check, and they are also given advice on the Northern Ireland Electricity Critical Care Register. Clients' responsibility to inform their house and car insurance companies. We complete the HOOF, which is known as the Home Oxygen Order Form, and there's usually 3 working days for BOC to process this. Once this is completed and we are aware that the patient has received their oxygen therapy, a follow-up is carried out by the respiratory team. In the next slide here, we have the Home Oxygen Safety Agreement Consent Form. This is not an exhausted list, but it highlights some of the dangers while using oxygen at home. And this is filled in, and the patient is educated on this along with the carer, and the patient signs the form, and the clinician also signs the form who has completed and educated the patient on this. A copy is given to the patient and another copy is retained within the patient's documentations. Oxygen safety is paramount. There is risk with oxygen and it can cause fire if it is not used appropriately. So this is very, very much given to patients, and they are made aware of the dangers that can happen if they do not adhere to oxygen safety. The oxygen concentrators. They utilise a modular sieve to absorb gases and then venting the nitrogen. This leaves oxygen as the primary gas remaining. Within the home, there is a standard concentrator on the left and the home fill system on the right. And these are the 2 main devices that you would see in the home. The standard concentrator more so than the home fill system. You should also be aware that there is a high flow concentrator which is very similar to the standard concentrator, but it delivers a higher flow of oxygen. Oxygen cylinders. There's many types of oxygen cylinders available and that you may come across within the home. There's F and AF cylinders, CD, DD cylinders, and ZA cylinders, and care must be taken in the storage and handling of these equipment. They should be kept upright, kept away from heat and anything flammable, and the patient and the carer are also shown and demonstrated how to use these cylinders. Within the community, there is also transportable concentrators available to patients. These patients have to be assessed for these specialised equipments because not all patients will be appropriate for them, and they have to be able to manage them and meet the criteria for same. The different ones available include an imaging device, which is pulsed oxygen, a portable concentrator, and there is also liquid oxygen. But those patients have to be assessed by the respiratory team in the clinic to see if they are appropriate for these devices. Oxygen is subject to change and procedures are to be finalised. Firstly, for BOC, we must highlight on the hoof, which is the prescription form, in the additional information if the patient has tested positive for COVID-19 or they are suspected of having it. Ensure the family member and carer number is visible on the form for BOC to contact. BOC will contact the family member prior to delivery. Engineers have PPE but will contact the family member in advance of delivery to advise oxygen concentrator will be left at the door. The concentrator will be pre-adjusted to the appropriate flow rate, and then the family member will be contacted to talk through same. If there's no relatives, technicians will don PPE. If a patient is positive and requires CD cylinders refills, they will not be uplifted until the patient is no longer positive. CD cylinders will be left at the door and family advised in advance. If the patient is suspected to have COVID-19 and requires refills, BOC will request that the empty CD cylinders be left at the door. There will be an additional presentation on acute oxygen and emergency oxygen. At the moment, there will be packs made up for the patients, but the biggest thing is to ensure that oxygen safety and consent is completed. This will be left in the COVID-19 patient house, and advice will also be given. The information that has been given to the patient and consent gained will be documented on the patient's notes or paras.
Okay, so these are the CD cylinders that you'll see out in the house. Whenever they come to the patient's house, there will be a grey tab over this with like a ring pull in it. So basically you have a canister of compressed gas, and this is a safety valve and it's closed on arrival, so this stops the gas entering into the head. So they pull off the ring pull and they open this valve at the side, and this allows the gas up into the head. Okay? This is where you attach your oxygen giving device, so that may be a set of nasal cannula or a mask. At the back here then you have your gauge of full and empty. Okay, so whenever you do open it, the needle should pop up to the green, and roughly these cylinders running at 2 litres per minute, you would roughly have about 3.5 hours in them. Okay, so to always check the patient, check how full the cylinder is before they take them out and about. and making sure that their hands are nice and clean before they change the nasal cannula, all right, because you don't want any grease on the valve, all right. So whenever they have a prescribed flow rate, so it may be 1 litre, 2 litres, 3 litres per minute, then they adjust that at the top and they just turn it on. So that will be 2 litres per minute, okay? And that should be the oxygen running. And then whenever they don't need their oxygen anymore, they need to be reminded to turn it off, because this is a cylinder and it will run out. They're encouraged to store their cylinders upright if they can. They can take them out and about in the car, but they need to make sure that they inform their car insurance that they are an oxygen user and that they are carrying cylinders in their car. And if they are going to put them into the boot of their car, they can lie them flat, but to ensure that they either put something up against them so they're not rolling about in the boot of the car. And in the car, they can store it in the footwell underneath, or they can just sit it between their knees in the car. When the cylinders are not in use, it's encouraged that they turn them off, and to replenish their supplies of cylinders, if they just ring BOC and inform them that they need whatever amount of cylinders, then BOC will deliver the next working day. Okay? So this is an oxygen concentrator, and this is what you'll find if somebody is on long-term oxygen therapy in the house. There is another one. It's a high flow concentrator, and it is grey in colour and it's slightly taller, but these are the ones you'll come across most commonly. The other ones just can go up to 9 litres per minute. These only go up to 5 litres per minute. So if somebody has been prescribed long-term oxygen therapy, BOC will have delivered one of these to their houses. So it's just plugged into the electric. BOC will set the flow rate that has been prescribed for them, and then there's just an on-off switch, okay? The nasal cannula will be attached to here. BOC will have an attachment on with an oxygen firebreaker, which is like white plastic and it's cylindrical, and they will have that all pre-set up for the patient, okay? You turn it on here, and BOC will have it preset to the flow rate. If you need to adjust the flow rate, which you probably shouldn't need to do unless it's under the instruction maybe from the HOSAR team or from the consultant. You need to be at eye level, just like in the hospital, and the ball needs to be sitting. The line needs to be in the centre of the ball, and you just adjust the flow rate by turning this meter. Okay, there is a little bit of noise from them, so if they are in a patient's house and they're complaining about the noise and it's on a wooden or a tiled floor, you can recommend that they maybe get a piece of carpet tile or a rug, and they can set the concentrator on it, and that might absorb some of the noise for them. It does run off the electric. So it does, and if there is a power failure, whenever it's delivered, they are supplied with a backup cylinder. So if there is, in the event of a power failure, they go on to their backup cylinder and they contact BOC to let them know that there is power failure. And then their backup cylinder will need to be replenished. There is lights on the front, so the machine will alarm if there's a problem. So if the red light is coming on or the machine is making alarm sounding noise, they need to ring this telephone number on the front, and BOC will come out and do a home visit and replace the machine, or else service the machine if necessary. They can also be used with masks, and these are the masks that you will see in the community. So these are the oxy masks, and they can run at any flow rate, so they can. And sometimes these are quite good if maybe the patient's nose is sore, or if they are a chronic mouth breather, or if they have a blocked nose, they could use a mask for a period of time until that settles down again. So there is portable concentrators out there in the community. This is the most common one that you will see, and people will refer to it as an Inogen. So it is a portable concentrator, so it takes in the air and it concentrates it down, but it only delivers a pulse dose of oxygen, so they're not getting a continuous flow of oxygen. So it's not suitable for everybody, only really people who are on quite low flow of oxygen, so maybe 1 or 2 or 3 litres for ambulating. They come with high flow nasal cannula. So they need to just make sure that they have the high flow nasal cannula for these devices, which BOC will give them. The settings will be preset. We'll have done that at the Hussar clinics, the oxygen clinics, and they basically just turn it on and they go out and about, and the battery will last maybe a couple of hours depending on the flow rate that they're using. The flow rates are in setting 1, 2, 3, 4 and 5, and they will be predetermined. And then it's rechargeable, so they can just, wherever they go to, they can plug in their charger and keep it charging while they're out and about. It's not meant to be used through the night, so it's not. And if any of the alarms, if the machine alarms or if any of the lights come on, they need to contact BOC and they will come out and either service the piece of equipment or replace it. So that's the most common portable device that you'll see out on the community. The only other thing really to draw your attention to is any of the patients who may be wearing these yellow armbands. So it says on it COPD, low flow oxygen please. So these are our patients who likely have type 2 respiratory failure. And if you give them high flow oxygen, you can actually make them quite unwell and tip them further into type 2 respiratory failure. So if you see them wearing a yellow bracelet, or sometimes they have an alert card, it's just to be aware that they can't tolerate high flow oxygen, so they can't. That's it.